Hello, my name is Anoop Patel. I am a pediatric epileptologist at Nationwide Children's Hospital and an associate professor for the Ohio State University College of Medicine. Today I'm going to be talking to you about quality improvement and outcomes research. We have several objectives to cover during our time together, and you can see them listed on the slide. Specifically, we're going to define quality improvement and list some aims that have been listed for quality improvement purposes. We're also going to talk about several quality improvement models. Hopefully you'll understand how to use quality improvement in your practice and education plan. Identify some study designs and other methodologies that are used in patient outcomes research. And then also how to specifically evaluate and write manuscripts for either QI or for outcomes research using some criteria that's been previously established. I always start out my presentations with this quote: "Quality is never an accident. It's always the result of intelligent effort." It was said by a 16th century philosopher, John Ruskin, and I think that's very apropos for what we're going to discuss and this movement of quality improvement and outcomes research. We're going to begin with a story of the history of how this became to be known in medicine. It was originally done by the Institute of Medicine when they reported a series of papers called "To Err is Human: Building a Safer Health System." It was originally published in 1999, and during that publication, they went over 6 aims for changing the healthcare system. The 6 aims are listed here. They're safe, effective, patient-centered, timely, efficient, and equitable. Those were the 6 aims the Institute of Medicine said we should implement to avoid injury, to decrease harm, and improve the quality of care that we're given our patients, regardless of their disease process. The definition of quality improvement is as such: systematic and continuous actions that lead to measurable improvement in healthcare services and the health status of targeted patient groups. The IOM defined the definition as such listed on this slide. They helped set the framework of what was important for us as it relates to quality improvement for patient care purposes. But why should we do quality improvement? Well, I mentioned it improves patient care, but it also improves patient satisfaction. It can help utilize healthcare resources more efficiently and effectively, decreasing the harm to all and risk to all, but also saving money. There are multiple quality improvement models. We will focus mostly on the Institute of Healthcare Improvement, or IHI model. However, there are Lean Six Sigma, which we'll briefly discuss, FADE, and some others that we'll briefly discuss as well. Specifically, let's start with the Lean Six Sigma model. The Lean Six Sigma model is a model that is usually used in the business world. It was originally developed by Motorola in 1986, and it's really built on eliminating 8 types of waste, which we'll talk about now. Specifically, they use this downtime process. So their 8 types of waste spell out the word downtime. So defects, overproduction, waiting, non-utilized talent, transportation, inventory, motion, and extra processing. Specifically, you'll see that these techniques can really be utilized in clinic flow or inpatient flow to improve and decrease the waiting and overproduction that commonly is associated with those specific care settings. FADE was developed at Duke University, and it's more healthcare specific. And as you'll see, all of these care models and ideas are very similar with overlapping themes, but it's important that you pick the one that works best for you in your care model and care setting. The Duke folks specifically made FADE: focus, analyze, development, execute, and execute, which spell out the word FADE. Specifically, you're looking to implement changes in the execute phase. However, you're doing it over and over because you're also trying to improve upon what you've started and learned. The care model was developed at Cornell, and it consists of 3 overlapping spheres in which chronic care takes place: community, health systems, and provider organization. And again, it's a very care-centric or healthcare-dependent model. In this model, there are 5 core elements that are important for you to know. You need to understand the health systems, your delivery system design, your decision support, clinical information systems, and also self-management support. The IHI model, which again is the model that is mostly used in healthcare and the one that we'll be focusing on for the duration of our quality improvement portion of this webinar. It was a model declared and set forth by Don Berwick in 1991. It is a model of improvement that can be implemented in any healthcare system. Let's dive into the essentials of quality improvement. I really want you guys to have an understanding of what is quality improvement and how you can implement that at your given practices. More importantly, it's the science of how to make, achieve, and sustain change. It's really what, as an organization, you would like to achieve in regarding quality and safety goals. It's also a way you can achieve your financial goals, specifically as it relates to customer service or decreasing healthcare waste. So reality, it's under a fundamental question. So where are we going and what have we done so far? But to understand that question, you must have data. Now, data can be in a multiple different areas. It doesn't have to have a robust system that you have to glean from. It could be specifically the time it takes to move between steps in a healthcare system or the number of handoffs, for example. Most people are used to data in relation to work in progress inventory levels or move distances or queue times or etc. But again, it can be in a lot of different areas. To understand quality improvement, you really have to have a system of profound knowledge. Not that anybody has to have a degree in psychology or these specific areas, but it does help to have a basic understanding. You must have an appreciation of an overall system, specifically the system you're trying to improve. You also have to have a knowledge of variation. You're going to use specifically quality improvement techniques to understand this knowledge of variation, but again, it's important to have an understanding or at least an awareness from the beginning. There's also a theory of knowledge that's going to help you understand the limits and the concepts you're trying to understand. But overall, we're trying to change human behavior. So having a basic understanding of psychology or knowledge of psychology will help you be successful when implementing any quality improvement projects. Certain techniques can be used, such as motivational interviewing, behavioral economics. Those are very good tools to understand and learn to help you achieve success when integrating a quality improvement project. However, no matter what model you decide to use at your institution for quality improvement, we must speak the same language. In this model, for the IHI, I would like to teach you our language that's used mostly in healthcare. And that model functions under 3 fundamental questions. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in an improvement? The way we get those questions answered is through this concept called the Plan, Do, Study, Act cycle. A PDSA, or Plan, Do, Study, Act cycle, is listed in front of you. The plan phase is the who, what, where, when, and why. In the do phase, you're actually carrying out your plan and starting to document any problems or unexpected observations. You're not going to do a robust data analysis, but you're going to begin this process. During your study phase, you'll interpret what you have collected, compare that to the predictions that you thought of in your plan phase, and summarize the learning. During your act, you'll either make changes to your cycle based on the unexpected observations or problems, or implement another cycle in either the same format or a wider stage. So let's begin to talk about the different questions we're trying to answer. What are we trying to accomplish? And that is written through an aim statement. The important thing to remember when discussing an aim statement that it must contain all 4 components that are listed here in bold. Again, I'm going to repeat that. These are one of the few things I want everyone to understand. To do a good aim statement, you must include all 4 of these components. If you do not do that on the front end, it'll make your project very difficult to actually implement and for success to be had. So you really want to be thoughtful about what the project will increase or decrease, specifically what group or population you're going to target, what your baseline is, meaning where you're starting, so from what, to where you want to get to, your goal. The other thing that it's important to remind you of is the time frame. You want that to be listed as a date, and you also want to know how long do you plan on continuing that improvement cycle. To list and to show your work in the IHI model, a key driver diagram is utilized. The key driver diagram tells the story in an organized and concise way. If anyone who has understanding of key driver diagrams sees your project, they should understand exactly what you're trying to accomplish. The key driver diagram is really broken down into three areas: your aim, your key drivers, and your interventions. And we'll speak to those specific parts in the next few slides. Here's what the diagram overall looks like. One of the things you really want to point out, is the arrows. The arrows go from right to left on this diagram. However, your project conceptualization will start with your specific aim, then you'll develop your drivers, then you'll do your design changes or interventions. This is why we start looking at the diagram in this fashion. If your interventions are pointing to drivers and then pointing to your specific aim, and it's all done properly, you'll see success in your project. What is a key driver? Well, it's a group of causes or factors that influence your aim that you need to help your team focus on by implementing interventions so you can see improvement. Think of it this way: what is preventing me from achieving my aim? What are the main influences which contribute directly to the aim? And you obtain these key drivers by utilizing quality improvement methodology techniques such as Pareto charts, cause and effect diagrams, process maps, and other key ingredients. I'll talk a little bit about what some of these things are. A cause and effect diagram is actually also known as an affinity diagram. The other way we think of this is a fishbone diagram, meaning the head of the fish is your problem or thing that is preventing you from achieving your aim, and the inputs or the spines of the fish are the causes, and therefore then can be used to develop your key drivers. So specifically, it can be done in a group or team effort. A Pareto chart is very helpful for those when you want to stratify the most common reasons why your certain problem exists. A nice chart can help you determine these are the specific targets or, quote, low-hanging, end quote, fruit that you need to focus on to help get success in your overall project. A process map is a step on a map that will help you guide you through your specific process that may find certain areas of waste or redundancy that need to be changed and done more efficiently for you to be successful. Those specific pain points can be then developed into key drivers. Now, an intervention is the specific test that you will facilitate to really overcome or lead to the improvement of your driver. The arrow that we saw on the previous diagram helps you understand that intervention is pointing to which specific driver. It's important to remember, though, a single intervention may impact more than one key driver. That actually makes a better intervention because you're getting, quote, more bang, end quote, for your buck. The ways we identify interventions is through change concepts that other people have published before you as it relates to topics that are similar to yours. Best practice expert consensus, so what has been reported in the literature as far as best practice goes, or what are others around you utilizing or implementing as far as best practice, and there are other techniques as well. But how will you know that a change is an improvement? And that's where you must have measures. And measures must be identified for every project before your implementation occurs for your project. There are three basic measures that we're going to be talking about. There's outcome measures, process measures, and balancing measures. Specifically, an outcome measure is how the system is performing and what is the ultimate result. This is really what patients care about the most. It is what the patients really get affected by. Is their care better? Is their quality of life better? Is their symptomatology decreased? Those are some examples. Process measures are really the parts and steps in the system, and are they performing as planned? Many of our current quality measures that we have endorsed either at the American Epilepsy Society or have been written by the American Academy of Neurology are process measures because those steps need to be in place before you could see a proper outcome. A balancing measure is, are you creating new problems by implementing certain changes to your current system? It helps you understand the fullness of what you're trying to implement, any potential downstream effects that may occur. Now, what changes can we make that will result in an improvement? Again, that is interventions. However, you must test your interventions in the real-world setting. You do not want to implement a large change or intervention to a system without testing it first. If it fails on a large scale, you're going to feel really horrible and have made changes that may not be easily adapted or undone. The way we do that is, again, this concept called Plan, Do, Study, Act Cycle. Think of a PDSA cycle as a small test of change, and then you can answer your question, did that PDSA cycle result in an improvement? If so, perhaps your project or intervention in this specific example can be rolled out in a larger frame of mind. How do you choose a quality improvement project? Well, this is a quote from one of my colleagues here at my institution at Nationwide Children's Hospital. He always says, healthcare is a terrible thing to waste, and that is very true. Look around you. You will find lots of opportunities for improvement. We have plenty of examples on a daily basis that you could utilize to improve at your specific institution or practice. But when you think and choose a quality improvement project, please be very mindful of scope. Sometimes it's very difficult to implement a project because your scope is way too large. You need to start small and build on those successes before you look at doing something on a larger scale. So that's very important that you also think of a good time frame to execute what you're trying to accomplish. If you pick a small or short time frame, you may not see the successes, largely because you did not give yourself enough time. You also need to be very careful of choosing the correct team. A team is very important to the success of your project. A project charter can be very helpful for you to decide who should be on your team and to keep you focused when beginning or choosing a quality improvement project or a quality improvement project idea. When you look at a project charter, there are some definitions that can be very helpful for you to think of. A problem statement, the aim, which again you'll use as an aim statement or in your key driver diagram, the scope, which we talked about before. What is your primary metric? What's your overall goal for this project? And then you may want to be considerate of a secondary metric, meaning what are the other changes that may be seen? Perhaps this is where your outcome measure will be listed, where your primary measure may be a process measure that leads to an outcome, which again could function as your secondary metric. Now, we're going to move on to outcomes research. Outcomes research is a very exciting area of medicine that's recently taken on a lot of fervor in the field of epilepsy and also outside the field by epilepsy. It was defined by the Agency of Healthcare Research and Quality, or also known as AHRQ, and really it helps us understand the end results of certain healthcare practices and interventions. It also allows us to measure the outcome of medical care that's given that will help us determine the quality of care that we give on a regular basis. Most importantly, can you achieve similar outcomes in different practice settings based on the results that have been published through outcomes research? Let's talk about a little of the history of outcomes research. Really, originally it was developed as a method for quality assessment based on the three different measures or metrics. So structural measures, process measures, outcome measures. A reminder, a structure measure is what are the things that are currently in place that might lead to success of a certain intervention. So for example, do you have a good level 4 epilepsy center in place with the resource that's necessary? A process measure are the steps needing to be enacted for you to see improvement on a certain area that leads to an improved patient outcome. Do you have a good understanding of being able to refer or evaluate a patient with treatment-resistant epilepsy? An outcome measure is, quote, where the rubber hits the road, and we'll talk more about that in the next coming slides. But specifically, did the care improve for the patient? Specifically, in our examples that we're listing so far, did the patient's epilepsy improve so their seizure frequency was reduced, which is really what we intend and want for all of our patients who are living with epilepsy. But why is it important? Well, outcomes research can help us understand how variations affect the practice of healthcare. We can also learn what are best practices, and do the current best practices actually lead to improvement in outcomes or in quality of life for patients, in our example, living with epilepsy. We can also determine the impact of the different interventions that are implemented for patient care. If you really want to isolate or understand how specific changes to the healthcare system improve outcomes for patients, this is another way we can achieve that goal. It's really what matters to patients and families. I mentioned the word rubber hitting the road. It's where the most impact is seen. It's what our patients care about. Did my disease process get better? Did my quality of life get better? Did my fill in the blank on anything you want as it relates to the disease state the patient has? And did that get better? It's the major reason most of us went into healthcare, to improve lives, and then as a side benefit, hopefully not to waste money in healthcare. How is it done? Well, you must really use an increased reliance on standards and guidelines that have been previously reported in medical literature. You also need to collect data. Without data, you're not going to know if your patient population is improving. You also need to be able to analyze and pool that data. That might be obtained through centralized databases or registries or a learning healthcare system. Currently, there are 2 learning healthcare systems being developed for the field of epilepsy, one in pediatric epilepsy and one in adult epilepsy. Those learning healthcare systems will allow us to be able to collect data, pool it, so we can understand and learn together, and then analyze it to see what happens and gets reported. Then, a dissemination of the results and a modification of the guidelines may occur based on information and data collected. Let's compare outcomes research to what we're more familiar with, which is clinical trials. So they're not developed in isolation. It's important to remind us that outcomes research is not necessarily completely different or done in isolation from clinical trials. Outcomes research has really progressed beyond just looking at studies of effectiveness. They are now looking at much more robust and also partnering with clinical trials. Clinical trials often include now measures of health status, quality of life, and resource utilization. Those are examples of where outcomes research has really worked well and now in concert with clinical trial and clinical trial design. It is meant that outcomes research to complement and not compete with clinical trials. The value of doing outcomes research is listed in these bullet points, but not necessarily all-inclusive on these bullet points. There are many, many more values or reasons why outcome research can be done, and it should be done successfully. Here, we list some more important issues. So, for example, better to provide information on informing patient decisions when you're next to a patient and want to learn what is the right course of treatment. Outcomes research can be of benefit. It can be used to guide healthcare providers in that sense. On a global scale, it can be done and used to inform health policy decisions. It also can study the impact of implementing quality measures in various practice settings. Specifically, when quality measures are designed for the field of epilepsy, one of the things that's important is to study those quality measures to actually see if those quality measures lead to improvement for patients. Again, if those process measures, once implemented, leads to better outcomes for patients. Those are values of outcomes research. When you make decisions, that's another benefit for using and utilizing the techniques in outcomes research. Those can also determine cost effectiveness. It's important that we understand the concepts of cost effectiveness as we are stewards of healthcare dollars and must inform our patients correctly and implement different tests or interventions or treatments that are cost-effective based on outcomes research. We mentioned data and how important it is to have data to do good outcomes research and also quality improvement. So it's essential to the success of any outcomes research project or quality improvement project. However, it's important to note that accurate data is important. So it's important that you have a method or somebody else has had a method of validating that data to understand and make sure it's accurate. So you are interpreting the data correctly and making changes as a result correctly. So what are some focuses of outcomes research? Well, we talk about some of these aspects in healthcare currently. Quality of life measures are a great way to focus on outcomes research. If you would like to measure the quality of life of your patients given a certain disease state, or in our example, epilepsy, over time, you could see changes and improvements or worsenings that can help you. That's an example or a focus of outcomes research. If you want to look at comparative effectivenesses of certain treatments, so for example, what treatment is truly better for new onset focal epilepsy in children with pediatric epilepsy, then comparative effectiveness research can be an effective tool for us to answer that question. Using and utilizing interventions to determine the effect on cost of care can be another focus of outcomes research. The quality of care we mentioned significantly throughout this portion of the webinar, but again can be very important for us and should be a focus of outcomes research. If you would like to see the effectiveness of shared decision making, that is another focus of outcomes research, and also looking at patient-centered outcomes or patient preferences. More importantly, we see this a lot in the field of epilepsy, is access to care, and are there interventions out there that improve the access to high-quality epilepsy care? What are benefits for the patient? Well, patients benefit significantly for us participating in reporting outcomes research because this is what they care about the most. They can have an increased participation in their own decision making based on shared opportunities between the provider and the patient or caregiver. Choices are given, or increased choices can be given, based on having a better understanding of the evidence or outcomes research that's been published previously. You're also going to be able to look at interventions and how they can be used to improve well-being. Those are direct benefits to patients and can be a sign of improved quality of life, which again is an example of outcomes research. What about to the provider? There are significant benefits to the provider where you can have a better certainty of the benefit of the intervention you're implementing, whether it's a certain treatment or a change in your practice model. You can also be able to implement guidelines or quality measures to really inform your clinical practice. No longer are you using the art in the sense of medicine. You're using specifically evidence or specifically guidelines to guide your implementation of certain interventions to improve care. It's important to note guidelines are created based on evidence-based practices, or in some cases, systematic reviews are formed. Guidelines and systematic reviews are then used to develop quality measures. Quality measures are operationalizing guidelines when there's a demonstrated gap in care. If everybody was performing at a high level for the guidelines, there would be no reason to implement or to really develop that quality measure. However, in most cases, when guidelines are created, there seems to be a gap, and hence an importance of a quality measure to guide clinical practice. Quality improvement can then be used to help you improve that performance on a specific quality measure that was developed based on a guideline. There's the flow of how this can be done, and when you report it, using some of the techniques we'll talk about in a few slides, you can now know if your effect was positive or negative. More importantly, from a provider benefit, you have a shared responsibility with your patient or caregiver. You demonstrate the value of the care you provide. Currently, we are in a world where it's important to demonstrate the value of a neurologist or an epileptologist. Here's a way to achieve that goal. Your organization benefits because they see greater use of effective interventions, and they also see decreased use or discontinuation of ineffective practices. Therefore, there's decreased waste in the system. So it's a really great goal for an organization and a culture that's emphasizing high-quality care. You will likely see cost savings, which is also a benefit to the organization at large and shows value of the care you specifically provide. For the government, outcomes research can help determine or showcase cost savings, how planning healthcare services should be performed, might also serve to subsidize effective treatments or pharmaceutical treatments that may be too expensive for most patients, or some services or important information that should be obtained or given to your patients that the government can help disseminate. Potentially, with the government and their funding sources, this outcomes research can help determine which targets should be had as far as research goes for the future. What the government is now looking to do is to use outcomes research to determine where there are potential greatest impact, and those are where funding dollars will flow. So let's talk about some of the ideas or areas that you see with relates to outcomes research. There are systematic reviews, which again I mentioned earlier, and we'll talk a little bit more about in a minute. There's decision modeling, retrospective analysis of the data that you currently have in a registry or database, prospective observational studies. You've heard these other concepts called the N of 1 trials, and you'll hear more about that as we move forward in healthcare within the field of epilepsy. With systematic reviews, it's important that these are not done without thoughtful consideration. So you first need to frame your question. You identify relevant publications. You assess the study quality, summarize the evidence of the studies you are assessing, and then interpret those findings based on certain methodology that's been in place. You've heard of some specific methodology, such as the grade methodology or method methodology, that can be used and helpful for us when we're trying to perform systematic reviews. Analysis is a key, and the way you use analysis or statistical reporting of the data you're interpreting is based on some of these that you see in front of you. Propensity scoring, sensitivity and specificity, subgroup determination and analyses specifically, adaptive design, or using instrumental variable models. Some key highlights on an overview for some of these techniques. Propensity scoring is a statistical matching technique. It creates a quasi or a like control group. What's important to know about propensity scoring, it's used to identify the effects of an intervention or treatment by accounting for the covariates that predict receiving the intervention or treatment. If you don't account for all the other factors around you that might explain the result of your intervention or confound your intervention, you will not get the answer that you're desiring, and propensity scoring can be a technique that can help with that analysis. Where if you look at instrumental variable models, they can be used to understand and identify relationships and health outcomes. These tools are used to implement to decrease type 2 error bias and estimates. It can help you identify causal effects in the presence of confounding issues, which again is what we refer above as either bias estimates or type 2 error. For years, it's been used in the political world, and now you're starting to see use of this within the medical literature and healthcare world. Let me give you some examples of outcomes research as it relates to our field of epilepsy. If you're evaluating the cost effectiveness, mainly the return on investment for a medication based on the price that's currently placed on that medication, using healthcare utilization impacts, that is an example of outcome research. Let me give you an example. If I am studying treatment X for the use of treatment-resistant epilepsy, and I would like to look at the impact, meaning my impact of that medication on decreasing ER visits or ED visits or healthcare hospitalizations or unplanned hospitalizations, that is a valuation of cost effectiveness. I also can look at quality of life. That's a patient-reported outcome. Currently, we recommend screening and also following quality of life for all patients with epilepsy. Therefore, once you implement your specific tool or intervention, you can now use outcomes research by following it over time to see if improvement or worsening is seen as you implement or change your current health system or institute a certain treatment or medication. Another example is the impact of time, back to that access to referrals to epilepsy centers. If you decrease the time it takes to refer a patient to an epilepsy center or improve the time of a patient being seen once referred, that's again an example of a great outcomes research within the field of epilepsy. Let's focus now on publishing. We're going to focus on different areas of publishing as it relates to quality improvement and outcomes research. There are acronyms that I want all of us to be familiar with and are listed on this slide: SQUIRE 2.0, STROBE, and RECORD. SQUIRE 2.0 is a revised version of the Standards for Quality Improvement Reporting Excellence. STROBE is strengthening the reporting of observational studies in epidemiology. And RECORD, reporting of studies conducted using observational, routinely collected health data. Let's start with SQUIRE 2.0. You've implemented a quality improvement project at your institution and are now looking to publish it based on the successes of your project. You would like to use and should use the SQUIRE 2.0 guidelines. All of these guidelines are available online. They serve as a framework for how you publish quality improvement. It's important to know that SQUIRE may be adapted for reporting the range of improvement approaches. So by no means do you have to use one technique to report using the SQUIRE guidelines. All of the techniques used for quality improvement purposes should be and can be reported via the SQUIRE 2.0 framework. It's important, though, that you know you should consider every SQUIRE item, but by no means should all your elements need to be listed in your particular manuscript submission. Again, let's repeat that. The authors that published SQUIRE 2.0 said you do not have to have every area of the SQUIRE framework listed in your manuscript when publishing or submitting for publication a quality improvement manuscript. You should only use the ones that are pertinent to your project and important for the framework that you are reporting. The SQUIRE glossary, though, contains many definitions of keywords that are used in SQUIRE guidelines, and examples of those are available on the website. When implementing or using any SQUIRE guidelines or the other techniques or framework we're going to discuss, it's also important that you cite this and list that this is how you've structured or provided the framework for your manuscript that you're submitting for publication purposes. When publishing outcomes research, there are various tools or frameworks that can be used that are very successful for organizing your manuscript. Checklists are available online on the STROBE website that are listed in our references. Checklists are also available for the other techniques and again are listed in our references. STROBE is used for publishing observational studies. Some examples of observational studies that you may want to use STROBE as a framework for publishing your manuscript would be case control studies, cohort design studies, cross-sectional studies. It's utilized as the most common framework currently in the medical literature. It's used and endorsed by many journals and editors of the journals that we currently use and publish within the field of epilepsy. And again, please utilize the checklists that have been provided for you at no cost while online. RECORD is an extension of STROBE, so again can be utilized in outcomes research reporting when you're submitting manuscripts for publications. It is an international collaborative to report guidelines for studies conducted using routinely collected health data that you may want to report, from health administration data, electronic health record databases, primary care surveillance data, or disease registries. If you participate in registries, such as the one produced by the American Academy of Neurology, you may want to use the RECORD methodology or framework to publish or submit for publication your work. Once again, checklists are available online for this methodology that can be available to you at no cost, and those are listed in the references of this webinar. Here are those references. Before I close, I'd like to really highlight a few that I feel are extremely useful based on the information that we talked about during our time together. The Institute of Healthcare Improvement is a wonderful resource for quality improvement and quality improvement resources. A toolkit is listed on that website that can be utilized for your practice. AHRQ is also a great website for us to be able to utilize and have some tools for quality improvement. The three down below are the ones I recommended and talked about during the portion of publishing your work in quality improvement and outcomes research. They can be very useful because of the checklists that are available and the information that's listed on those web pages. With that, I would like to thank you and the American Epilepsy Society for your time for us to discuss quality improvement, the methodology, the techniques, and also outcomes research, the techniques and outcomes.